the Laborhood.
Welcome back.
I'm weak.
Welcome. Ain't that a song?
Yes.
Okay. This is Briea.
Hi. Oh, my bad. This is Shay.
And this is Briea.
Yeah.
My name is Briea. I am a nationally certified inpatient obstetrics registered nurse.
And I'm Shay. I am a board certified nurse midwife and also a nationally certified registered nurse.
Period. Credentials. So our topic today, I feel like sometimes she gets a bad rap. Just a little bit. Like, I feel like some things have happened to people and they went back and told other people and they were like, don't do this or you'll end up da-da-da-da-da. You know, like, I feel like that's how this thing has gotten a bit of a bad rap.
But a lot of things have gotten a bad rap because of that. Like, hospital births in general have gotten a terrible rap.
I can see that. But this thing is... she's necessary because
some people need it.
A lot of people need it because I've seen people come in needing this and you put them on the monitor and it's like, oh, baby, you really should have been here like a week ago. You know, like you see that, oh, thank God you came tonight, baby. Thank God you came tonight because this, if you had waited another 24 hours, this would be a very totally different situation. Yeah. So, if you're wondering, we kind of, we're hinting at what we're trying to talk about. But today's topic is induction. You've heard a lot of people talking about, I'm going to be induced, or the doctor wants to induce me, And, induction is, sometimes it's offered for medical reasons. Sometimes it's the patient's choice to want to be induced. Mm-hmm. And induction can occur in a lot of different ways, different stages, different time frames, different gestational ages, the types, how it happens, when it happens, all those things are very different and they're different for different people, but induction is not bad.
I don't think it's bad. No.
I don't think it is anyway. So, just this, I'm saying, induction's not bad. I know a lot of people don't like to be induced. I don't know their fear of it. And tell us how y'all got to that. Because I want to know. I think because we know what we know, I think it's kind of like, I ain't scared to be induced. Like, whatever.
Like, please schedule my induction.
Yeah, I'm scared to be induced, and we just kind of like, we don't think it's a big deal. But I would love to hear from people, why don't you want to be induced? Because I've heard that from
a lot of people.
I don't want to be induced.
75%.
Yeah, they don't want to be induced. Yeah. And again, I think it just comes from, unfortunately, people telling their horror stories about what happened during their induction and, how painful it was or how long it lasted, and you just hear a lot of things like that. And I think it deters people from wanting to do it.
All the bad stories make it to the internet. You don't see the good stories.
Every single last one of them.
all the bad stories.
They make it to the TikTok comments because I read them. So we're going to be talking about induction today, guys. So according to ACOG, which is the American College of Obstetricians and Gynecologists, labor induction is defined as the use of medications or other methods to start or induce your labor.
Very quickly, for those who do not know ACOG, this is like the standard research for everything obstetrics and gynecology related. All the providers follow this, the nurses follow this. This is the blueprint for pregnant women and gynecology things.
Yes. And you might hear us talk about ACOG. You might hear us mention A1, which is the A1 stands for Association of Women's Health Obstetrics and Neonatal Nurses, I believe. Neonatal nursing, something like that.
Yeah, very similar.
Yes.
And that's the blueprint for nursing standards.
Yes, for obstetrics and neonatology. So like NICU things. So we each have our own umbrellas of these associations that we fall under that give us our guidelines and protocol. Like we kind of use their information and their research to create protocols within the hospitals,
right?
Things that we follow and things like that. So you will always hear us mentioning ACOG or A1 because again, that's who kind of sets the standard for how we practice within the hospital. You know, you don't walk in at 30 weeks and just be like, I'm ready to be induced.
Some people do. They try to.
Y'all would like to, some of you, but that's not how it goes. There is a reason. There is a rationale as to why you are being induced. There are a few different ones. So there is elective, and that's exactly what it sounds like. It's the obstetrician or, you know, the nurse midwife they elect for you to be induced. They give you the option. They say, hey, you and baby look fine, but you have reached a point in your pregnancy where we can offer you an elective induction. Mm-hmm. Like, now, here's the thing that I think people, from a nursing standpoint, because I've seen it, especially with elective inductions. Okay. If the hospital staffing or gets iffy, or if there are emergencies going on the floor to where there is no bed available, sweetheart, you are going to have to go home.
Or you're going to have to wait.
Or you can sit in the lobby and wait for as long as you want, truly. But you essentially, when it comes to things like that, when it comes to getting into the hospital, getting a bed, unfortunately, you are at the bottom of the list because health-wise, you and your baby are perfectly fine.
Right. It would not be detrimental to you or your child to go home. Versus somebody else who it may be life or death.
Mm-hmm. That they get the bed first.
Yes. It is like triage 101.
Mm-hmm. Very much so. And I have had some patients be very, 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 very angry with me.
Agreed. Yeah.
That same. They come into the hospital, you know, when I was a charge nurse. I mean, angry. Like,
I was supposed to be induced today.
Yes. And it's like, I get it. I get that. I do. I understand completely.
But you waiting to stay pregnant another 24 hours.
Yeah. And with this,
it's not going to be that bad.
This particular patient, I think her husband was like working somewhere else and had flown in because her induction had been scheduled for that day. But when I tell you that floor was jumping, like, babe, I physically don't have anywhere to put you, nor do I have someone that is available to take care of you.
Yes. When that happened to me last year.
She was so angry. She was angry because she was like, she had 2 or 3 other kids at home. Somebody came in and was watching those kids. And so the husband was there at the hospital. But baby, she was over it and she was over me and she was not trying to hear what I had to say.
Ooh, okay.
At the end of the night, she went home.
I bet.
Babe, I literally had to go get a doctor to like lay it down for her because she wasn't trying to hear what I was saying. And I was like, I'm going to go get someone who can help us. And literally I had to go like talk to it might've been like the chief resident. And I was like, here's the situation. She is an elective induction. I don't have a nurse. I don't have a bed. And she is not trying to hear it. She had to go out and do damage control for me. Like it literally like made me like
cringy.
No,
it made you feel bad.
It made me cry because because I was already like coming into work and it was just fire. You know how you come into work and it's just fires everywhere. You're just putting out fires, and that I was just like, I can't do anything right. I can't do anything right. Nothing I do is right. All right. It was rough,
no.
And it was like the beginning of the shift. Like this was like 8:30. But after that, I was fine. But elective, yeah. Unfortunately, you are at the list of people to be called in just because health-wise, you and your baby are just fine.
So bottom line, inductions are unpredictable.
Mm-hmm.
Whether it's elective, whether it's medically indicated, inductions are unpredictable. Unpredictable. Okay.
Shout out to Jamie Foxx. I'm so glad he's doing better.
I am too.
I saw him on that boat. I was like,
I saw that thing that his daughter put out. Like, he's so much better. He's at home. And I'm like,
oh, thank God.
Okay.
I can't handle another boss. Okay. But so elective induction, I believe there are certain, it depends on the facility, because if it is your first baby, you can be offered an elective induction starting at 40 weeks.
Yes.
If it is not your first baby, you can start being offered an elective induction at 39 weeks.
Correct.
At 39 weeks.
Correct.
Again, elective means there are no other comorbidity things involved. Like
your blood pressure, your baby are
fine.
Healthy.
They are fine.
You've grown this baby for 9 months. Another 24 or 48 hours is not gonna be detrimental to you.
Not gonna hurt you, babe. Okay, that's elective. Now we have post dates, which is exactly what it sounds like. Post dates induction is the offering of being induced when you are over 41 weeks.
Yes.
Did I say that right? 41 weeks, which means you are 41 weeks and 1 day. That's post dates.
Yeah.
So
people automatically think like due date. There really shouldn't be like a due date. There should really be like a due week or a due month.
Literally.
Because just because today is your due date, one, that does not mean that you're going to have a baby today. And then two, that means that your body might not be ready.
Quite ready.
Essentially, a due date is a range.
Yeah. Literally.
Because it depends. Like, you know, some people, they don't know their exact first day of their last menstrual period.
Mm-hmm.
So it's like, we're kind of shot in the dark here. Mm-hmm. Yes, we can do an ultrasound, but even still, that's still a shot in the dark.
Yeah,
nothing is definite, right? 100%. So just because it's your due date doesn't mean you have to have a baby.
Correct.
Yeah. You may be offered an elective induction post dates 41 and 1.
41 and 1.
Yep.
Right. So yeah, we have elective, we have post dates, and now we have medical. Now, this means that there is something going on with you and baby where it's like, okay, if we stay pregnant longer, we're getting into some unsafe territory.
Mom, are your shirtless water sanitary? It looks questionable to me.
Right. It's safer for your baby
to be out than in right now. Yes. For either of you. Because sometimes baby is just fine, but mama staying pregnant is making her sick.
Right.
And so this is when we start talking about things like gestational hypertension, preeclampsia, gestational diabetes. And that's for mom. Or sometimes we will even see an induction happen when mom has chronic hypertension, which means she had hypertension before she got pregnant. Or if mom was a diabetic prior to getting pregnant. So she had type 1 or type 2 diabetes, you know, prior to getting pregnant. And even when we start talking about baby, there might be too little or too much fluid around baby. Baby's not growing at the exact rate that we would like baby to, whether it's real fast or kind of slow.
Right.
So there are a few different factors that we have to start playing in. And each one is different when it comes down to when you will be induced. I think now for gestational hypertension, I believe it's 37. Is it 37 weeks?
I was about to say gestational. So gestational hypertension, typically we don't treat gestational hypertension.
Right.
So I've seen them go up to 38. Like as long as their blood pressures are stable, we're not having to like medicate them.
Yeah.
We want them to get out early. Yes.
Right.
But typically, I've seen it go to 38, maybe even longer at 39. So it just depends on how stable the mama is.
Yeah. Which is why when we start getting towards the end of that pregnancy, which is why those weekly
checks are necessary.
That's why you're going to the doctor every week. Because if there is something going on within these last few weeks that we might need to get you in before 41 weeks, we're going to pick it up when we start going to these week to week appointments. Which is why it's so important to make sure you keep your appointments and go to the doctor. Thank you.
And let me just say, prenatal care is a large umbrella. However, if you're just going and getting ultrasounds, that's not prenatal care. No, you need to. No, it's happened multiple times. the patient will come in and I'll be like, where are you getting your prenatal care from? And they're like, oh, I've been going like once a month. I said, no. You're 32 weeks. Somebody should be seeing you at least every other week at this point.
Mm-hmm.
And they're like, huh? I was like, so you're not sitting down with like a doctor or anybody? Well, the doctor that does my ultrasounds, not the same thing. Not the same thing.
Yeah.
Okay. So make sure you establish prenatal care. And if you are in the triad area and you are worried about insurance, Medicaid, blah, slide in the DMs, we will make sure that you get to where you need to go.
That's right.
Okay. Continue.
Ain't nobody paying back a PPP loan. They can give y'all some free health care. Y'all be fine. Come have your baby safely, okay?
Please.
Don't worry about that. We'll get it figured out. Okay, so when we, talk about induction and we talked about why, but no.
Just to double back, reason you might also have an induction if, mama, you've got heart issues, like you got like mitral valve prolapse or something like that, or something is happening with your liver, or people get like cholestasis, or your gallbladder, or
I've heard that,
your kidneys, like your body is not being able to support you and baby kidney wise. Baby, we got to get your baby out.
Somebody got to go, and it's the baby. You got to get out of here. You got to get out of here. You leeching right now. You leeching. You got to go. Get out. Get out of there. Yes. I forgot about cholestasis, and I definitely treat.
Or even like infections, like chorioamnionitis. I never can say that.
There's an extra N in there. I skip over
chorioamnionitis.
Chorioamnionitis.
There we go.
Boom. There it is.
Sure.
I can say that, but I can't say CRNA. So.
I say choreo. What's choreo? The new thing they're calling it is triple I.
Huh?
Because there's 3 I's in choreo.
That's gonna confuse me.
Yeah. Okay.
I'm gonna say choreo. I'm gonna say it like
an
that.
infection either in the uterus itself or in the placenta or the membrane surrounding the baby, something like that. Yeah. Those are also reasons for, or even, rupture, like pre-labor rupture of membranes.
Yes.
Where your membranes have ruptured, but your body is not.
Okay, your water broke.
Yeah, sorry. Your water broke, but your body's not in labor yet. That may also be a reason for induction.
Yeah.
Okay, continue.
Because sometimes that happens pretty early. So, yeah. But yeah, so I was just kind of talking about like what induction looks like, because I think when people hear induction, I think they think, like, I have had family members come in full blown ready. It's about to be baby time.
No, it's not.
And I come back in the next 12 hours and that baby is still, she's still pregnant, which is fine, because I don't think it's discussed enough how long of a process induction can be. Yep. Because literally it's us trying to get your body to do something that it wasn't ready to do on its own, or it wouldn't do on its own for whatever reason. So it's us trying to try different methods, whether it's medical, medicinal, or, mechanical, to get your body into labor. And if your body's never done that before, or if you're on a medicine like magnesium that's literally fighting and counteracting what we're trying to give you, it can be like
push and pull.
It can be a tug of war thing for a while.
Yeah.
It can be, when I say a while, I mean like days. Like, I've seen a patient for all 3 of my 12-hour shifts. I didn't take care of them, but they were in that same exact room all 3 of my 12-hour shifts. And still, and when I left that third morning, baby, they still hadn't had a baby. But there are things and factors that happen that can cause that. So I think when we start talking about induction, I think we do have to understand that it can take a while, and not everybody's induction is the same.
Unpredictable.
Literally. So that's the theme song for this episode.
I think we should probably name it
that. Because, you have to start with that, like that ripening. And getting that cervix ready. Yep. We don't just jump into, Pitocin, unless
dependent.
Unless
there's another caveat to that, but not to confuse the girlies.
Yeah, we're gonna stick with it. We'll talk about it later. But so we really have to. It's another thing. It's like levels to this, because you got to work your way up to like getting it to that contraction. I think people think they come in induction, let's start having contraction. It's like, baby, you might not have a contraction until tomorrow.
I mean, no, seriously, actually.
You might feel some cramping, but you ain't gonna really start contracting until tomorrow, you know?
So how I think about it is, all right, if I'm gonna go and start training for a marathon, right?
Mm-hmm.
I'm not just gonna go out in my backyard and start running, right?
You're gonna pass out.
I'm gonna die. Anybody who knows me, Shay is gonna die. But there's certain things that I'm gonna do to prepare for this marathon, right? So I'm gonna stretch. I.e., number one.
Before and after.
Right. So we're gonna stretch. So think about it like that. The ripening of the cervix that has to happen before you start like physically contracting is your stretching before your marathon.
That's such a good way to put that. Do you say it to your patients?
I do.
Yeah, that's good.
Yeah. And Braxton Hicks.
Yeah.
Braxton Hicks are the stretching before the marathon.
That makes perfect sense.
Mm.
That's a good way. I'm gonna start using that in triage. I'm like, okay, girl, so listen. It's like a marathon. They're gonna love that one. I'm gonna write that down. That's so good. Yeah. But that's
literally what it is.
Way to think about it. That's the perfect way to think about it. Speaking of inductions and how we start them, there are about a lot of different things that we can do and give you like medicinal to get labor started, or to get your induction started, rather, to start your induction to induce your labor.
Quickly hit on like mechanical first, because that's like people are like, is there things to do? Can I induce my own labor? Yes, girl. There are things that you can do at home. I'm pretty sure y'all done seen TikTok. You can do mild circuit, curb walking, red raspberry leaf tea, evening primrose oil. If you really want to know my Labor Day readiness, slide in the DMs. Because that's a whole nother conversation. But there are things that your provider can do that does not include medicine necessarily to help you get your stretching done. You can do like sweeping of the membranes, where your provider checks your cervix and essentially releases the bag of water from the cervix to stir up prostaglandins that can.
They don't break your water.
They don't break your water. It's literally like putting my finger through a hole and like ringing,
like ironing it out.
Yeah, like ironing. Yeah,
like ironing it out.
And what it does is it stirs up your happy hormones, your prostaglandins, your oxytocin, those kinds of things to help your labor start. You can also do balloons, cervical ripening balloons. There are several kinds. You can do a Foley bulb. You can do a Cook's catheter. You can do a traditional Foley.
Yeah. A Foley bulb has one balloon. A Cook's cath is like a sandwich. It's like two.
It is like a sandwich.
Literally. It's two balloons. We blow up each of them. One is on each side of the cervix. So one is kind of sitting in the vagina. The other one is on the other side in the uterus on the other side of the cervix.
In between
baby the cervix and the baby's head. Yeah. So it just kind of like mashes.
Yes.
Together.
It thins it out mechanically. So if you ever hear anybody talk about like mechanical dilation, this is what they're talking about. They insert a balloon. It inserts a catheter through the cervix, no matter what kind it is. We fill it up with either water, normal saline, whatever the hospital's policy is. The pressure applied from the baby's head eventually pushes the balloon while it's full back through the cervix. And that will cause you to be at least 2 to 3 centimeters typically once it falls out. This can take a number of hours. It does not happen like overnight. Well, it can happen overnight, but it doesn't happen over like a 20-minute span. Yeah. Some offices will offer you a outpatient balloon where they'll put it in the office. Your induction, like let's say today is Wednesday. I'm going to put your balloon in today, Briea, but your induction ain't till Thursday night or Friday morning. Yeah. By that time, your balloon should be out, and now you're already ahead of the game. You done already did the stretching. Now you're at this.
Wait, you can do it that far in advance?
Typically, I mean, it depends. It depends.
Oh, you know what? Okay, but this just shows you how. I mean, I've seen it done before, but I thought literally it was like, okay, when it comes out, go to the hospital kind of thing. But it doesn't have to be that way, correct? Okay,
you're still feeling baby move. You're not having any vaginal bleeding, leaking of fluid, contractions every 2 to 3 minutes.
Stay in the crib.
Yeah,
cool. Didn't know that. Didn't know that you could like, because I thought it was just like okay, it's Wednesday, your induction is Thursday at midnight, I'm going to put it in now, and then by that time,
it should be out.
Yeah, it should be.
Relatively. And if your induction is scheduled for that day, then that's perfectly fine.
Gotcha. But it doesn't have to be.
Right.
Gotcha. Okay.
Now, I'm not going to put it in like a week before.
That's crazy.
No. But like you said, if today is Wednesday and your induction is for tomorrow morning or even tomorrow night or even early morning on Friday.
Like 7 a.m. Friday.
Yeah.
Gotcha. Okay. Well, that's good to know because I myself did not know that. So we talked about mechanical. So like, sweeping of membranes, balloons, whether it's a cook cath or a Foley bulb. But now we also have like medications that we can give you to start your labor process. Some of these go in your mouth. Some of these do not go in your mouth. Some of these...
Sorry. Please preface that.
Okay, what I mean by that is so we'll start with the ripening meds. So there's two. Sometimes you can use Pitocin, but we'll get to Pitocin in a second. There is Cytotec, or sometimes you might hear misoprostol. That's how I say it.
Yeah.
Okay, I heard somebody say it.
Miso.
Somebody might say meso or Cytotec. That's usually what I call it. So Cytotec is a cervical ripening medication that we give a couple of different ways. That's why I said some of them go in your mouth and some of them don't. So some of them are placed vaginally. So literally the nurse, it feels like a cervical exam. Your doctor or your nurse can place it. It's a tiny...
Depending on the hospital.
Yeah, which is crazy. Anyway. It's a little, literally, it's a piece of a pill. Actually, it's not even a whole one, typically, but it's placed behind the cervix. So it literally feels like
posterior fornix.
So it's like you put it in, like you're going to get your vaginal exam, and the nurse is going to place it behind your cervix, and that's just going to start, getting some things going. You might feel a contraction. You might not. You might just feel like it feels like a period cramp. Which again, like Shay said, that's just that straight. That's getting you going. That's getting that stretching going.
It softens and thins the cervix, so
like a peach, ripens it.
Ripens like a banana.
Makes it soft. Yeah. Yep. So yeah, like that. Now with Cytotec, it's not just a lot of times. It's not a one and done thing. Often I see patients get at least 2 doses of Cytotec. Oh.
Sorry. As soon as you said that, I was like, she's not going to catch.
No, didn't. Okay. But sometimes people will need a couple doses of Cytotec just to really get that cervix nice and soft, nice and thin, just to get their labor going. And there's also Cervidil. So Cervidil is a little string of medicine that goes in the exact same place, but this medicine goes in and it stays in for 12 hours. So am I right? Cervidil stays for 12 hours?
Yes. I was trying to think if people still use Cervidil.
Since when?
I remember something about like, one is mad expensive.
It that's why a lot of hospitals don't use it, because it's very expensive.
Okay. Is that the one? I'm going to look it up. But one, it's mad expensive. And then 2, like, I felt like because of the length of time that it takes to really, really work, people were like getting away from it.
Because just the pros don't outweigh the cons.
Right.
Kind of thing. Well, not really the cons, but it's just not conducive, I guess, to time. That makes sense. That makes sense. I can see that. So, of course, we have Cervidil. I was just matching together. Cytotec and Cervidil. Like I said, Cervidil is like a string.
It kind of looks like a thin tampon.
It's like a thin tampon. Like it has a string like one too. Mm-hmm. And I've seen doctors put the whole thing in their string and all. I think the string is supposed to hang out just a bit, because if you need to pull it, you just pull it. Anyway.
Yeah, but it's one of those things too, like, if I'm going to get it, I can go and get it. Like, it's not like a Cytotec.
I'm going to find it. If I need to do it, I'm going to find it if I need to pull it.
I've seen them do that too, though.
Yes.
And I think, like, nobody just wants that hanging out.
Cytotec me, baby. I don't want no Cervidil. But anyway. But also with Cytotec, like I was saying, some people, A lot of times it's given vaginally, but other times it can be given, I say buccally, so buckle, which is where it is placed in the cheek, between the cheek and the gum. And it just sits there and it just dissolves. And some providers even alternate. They'll be like, okay, the first dose, give it vaginally. The second dose in 4 hours, give it buccally. And then if they need another one, go back to vaginal. So it just depends.
I've seen it work both ways.
Oh, yeah. I
don't know. To me, I feel like if I can do it in my cheek and I ain't got to put my vagina on display, I'm fine with that. But
as a nurse, I'm not saying it's less effective buccally. Because if you rupture it and you won, baby, you're going to have to, obviously, I can't put nothing in there. You're leaking fluid everywhere. So I got to put it in your cheek. I don't know. I just feel like it's just something about when I put that thing in there. It really depends on who placing your side effect. That's the thing. That's the thing.
Because I can place a mean vaginal side effect.
Shay's patients are going to deliver off of one dozen side effect.
I place a mean side effect vaginally. However, as I'm developing my practice as a midwife, to start to kind of ease patients into a labor induction process, I will absolutely do a buccal side effect.
Okay. I mean, that's fine.
It's just, I don't know. I've seen it work both ways.
Yeah.
People that I work with say that they really like it buccally, that it absorbs a lot better, which I can see, because if you get it in some vaginal mucosa, it ain't gonna work.
Or in 20 minutes, your patient's like, I can't hold it, I gotta pee. Well, damn, girl. And you gotta pee that side effect right
on out.
And we had 3 hours and 40 minutes to go before I can place anything else.
Right. So, I mean, convenience-wise, I guess.
Yeah.
You can ask your provider which they prefer.
Yeah, for sure. And we talk about Cytotec, Cervidil, and balloons. These things can be used together. Not the Cervidil. Cervidil, that's its own thing.
That's by its lonesome.
You independent lady over there. But Cytotec, the little pill, and a balloon can be used together to start an induction. And that's a very effective combo right there. That's a very effective combo. And I've worked with some midwives. They love that combo.
Oh, yeah.
They love that combo. They love a Cytotec and Foley bulb combo.
With a little traction until you get up and go walk.
Because I'm taping it to the leg. Just know that. No, it's getting taped to your leg. Yes. But yeah, I've seen that work really well.
Yeah.
Now there are some certain contraindications to Cytotec. And that's if you have had a C-section before or some kind of cervical incision surgery, something. Not even typically. I actually think it's like a contraindication of the medicine in general.
It is.
You can't do it. You can't do it. Okay. No matter what the doctor thinks, you cannot have Cytotec. So if you've had a C-section before and you're coming in for induction, the doctor will. We're not using that. We're going to use something else. So probably like a balloon and some low-dose Pitocin or something like that to kind of get you going. Speaking of Pitocin.
I was going to say, speaking of Pitocin.
That's another girl that gets a bad rap.
Agreed. Do you know, I had a patient the other day. I looked at her allergy list.
No, it did say Pitocin.
Yes, it did. It said oxytocin. And I said...
Stop doing that. Stop putting stuff on your allergy list because you don't want it.
It literally said anaphylaxis with oxytocin. And the reason why I am not even upset, but the reason why this bothered me so much is because the synthetic form that we give you in the hospital is Pitocin. Pitocin, I think. Your body makes oxytocin. So there's no way.
She got an autoimmune disease.
I mean, maybe. Okay, I didn't do a lot of digging.
No, she don't.
I mean, I know she doesn't. That's like saying, I'm allergic to magnesium. Baby,
it's everywhere.
I'm allergic to water. Your body is like 75% water. You're not allergic. Okay? So that's what got me. She literally said she was allergic to oxytocin. oxytocin is a hormone that your body, everybody's body, makes naturally. This is your happy hormone. If you are living up on your boo thing, this is the hormone that's released. When you have sex, this is the hormone that is released. Yeah. When you orgasm, this is the hormone that is released. How you got here to the hospital, birthing center, home birth, whatever, your body was releasing oxytocin.
Yeah.
Okay. I am off of my soapbox now.
You feel about PIT the way I feel about PS5s in labor and delivery. Yes! So, Shay kind of gave y'all the rundown of Pitocin. It is a synthetic form of the natural hormone that your body makes, and we give it to you through your IV.
Yes.
And it's so, and I think, so a lot of times, again, like I said, I think Pitocin has gotten a bad rap. And people just automatically like, I don't want Pitocin.
Yep.
And it's like, okay, is there a reason why?
You want to talk about it?
You want to talk about why? And so I kind of explained that it's definitely a great teaching moment. Nurses, great opportunity to sit down with your patient and educate them on what Pitocin is, how it works, how we use it. And I think a lot of patients don't know that it is titratable, which means I only give you what you need. So if typically hospitals will start Pitocin at a dose of 2 milliunits per
hour.
Yeah.
Okay.
Because it's 1 milliunit per ml and 2 ml. Yeah, there you go.
Okay.
Yeah.
2 by 2.
Take me back to nursing school. Okay. That was a dosage calculation that I just did in my head. Okay, but
most hospitals do the 2
by 2
method.
Mm-hmm.
Now there is a difference between low dose Pitocin and high dose Pitocin. Mm-hmm. Majority of hospitals do low dose Pitocin. We worked for a company that allowed high dose Pitocin in there. Like that was their starting. They did 4x4. So just check on your facility and see what they do.
But again, like I was saying, it's titratable.
Agreed. Yes.
So whether it's 2 by 2, 4 by 4, if I started at 2 and you only need 2, then I don't go. Then I never go up past 2. If it starts at 4 and you only need 4, then I never make it to 8 because I don't have to turn it up again. And that always shocks people. They're like, oh, I'm like, yeah, if I don't need to give you more, I won't give you more. And if we get to a point where it looks like you're having too many contractions, then I can also turn it down. Because I don't want to stress you or baby out. Right. I want it to be at this very happy medium area where you're contracting beautifully and your baby is doing just fine. That's where I want you to stay.
Again, this is a hormone that your body makes naturally. So even if you go into spontaneous labor, bump an induction, you go into spontaneous labor, your body is making oxytocin. And I'm, again, off of my soapbox. Well, I was thinking about, we had a doctor that swore that you didn't have to go above, like the body makes like 8 to 10 naturally.
Yes.
And he swore that you never needed to go up.
Yeah, it was on like 6 or something.
Yeah.
Never went past this. I don't care what you thought. Like the pit never, his patient, he never wanted them above 6 of pit.
Yeah.
Yes.
And as a nurse, that's how I practice. I need to do the research and really look into that, but that's how I practice. Like, I typically never have to go above 12. If your pit is above 12, I did not start it.
If your pit's above 12, I'm going to tell you another reason I've had to go above 12 on some pit. If my patient was on magnesium. Okay. And if I am trying to like fight that mag, I have had to go like hit like a 14.
Okay.
14, 16.
38?
Never my whole entire 7-year career.
I ever. Maybe like 22. And that's if the patient, like if I came and she was on 16 already. Right, yeah. If I came in and she was already on that much. Mm-hmm. But even still, like typically I've never had to go above like 12 to 14.
Yeah, agreed. I love a good, because I've had providers come in, she's only on 12.
And she contracted like a bench.
Like baby's crying, we're ready to have a baby.
Yeah.
You don't need all of that. And I think that comes from one, how you're taught early on, as far as like what hospital, what your preceptor taught you, and learning what labor looks like, what a good healthy contraction pattern looks like, learning to looking at the patient as a whole. Because what I've also had happen is I came in, that patient was on like 12 a pit, but it wasn't her first baby, and she had not had her water broken.
And sometimes that can be.
And the nurse was like, "Well, she's not hurting," so I just kept going up on the pit, and I'm like, I said, "Okay." Again, I said, "Okay." I went in the room. She was kind of starting to get uncomfortable. I said, "Well, 12 a pit. You probably are a little uncomfortable." She said, "I think I'm gonna get my epidural." She got an epidural, because by that time, now we're gonna break some water, and this is what's really gonna get her body's natural oxytocin is really about to kick in. I didn't touch her pit again.
Yeah,
didn't touch it.
Or even the ones that like they're on like this certain amount, and all they need is like a really good position check, or the nurse is not like titrating appropriately. Like, yes, you can go up on pit like every 30 minutes, but sometimes you don't need to. And sometimes you need to let the body like react to it first.
Because sometimes going from 8 to 10, sometimes that last 2 hadn't really started circulating yet.
Right.
So now it's going to feel like you're going from 8 to 12. And your uterus is going to be like, wah!
Exactly.
So, yes, it's definitely a thing of just recognizing what that labor pattern looks like. And almost, it's not seeing into the future, but it's like, okay, in 2 hours after we rupture her, and after she gets an epidural, and after her bladder has been emptied, and I put her on her side, now what is that contraction pattern going to look like?
Right.
And so it's kind of like, and this, it comes from experience. It truly does come from it. Because it's just kind of like, I'm gonna see what happens, and you just gotta call the doctor and be like, okay, so here's what's going on.
Right.
I think if we break water, we're gonna be good. And sure enough, that's usually what happens. But again, Pitocin gets she does get a bad rap. And I think I've talked about this in previous episodes where patients, they say, well, Pitocin causes you to have a C-section. And that's not true in that sense. And, listen, I'll go back over it because education is continuous, and I will repeat what I said before, but it's not the actual medication that's may or may not cause you to have a C-section. Like I said, what we talked about, Pitocin is titratable, and you have to find that happy medium.
Right.
And sometimes we skip the happy medium gets skipped over, and we get to a place where you're having too many contractions, and it's not giving your baby enough time to rest and recuperate in between contractions. And so the baby starts to get stressed out. And the only way that babies know how to communicate with us when they are stressed out is through their heart rate.
Right.
And then their heart rate starts to drop. And then that's when we have to start doing things. And if the heart rate drops and it don't come back up, okay, yeah, sure, you're going for the C-section. But it's not necessarily the Pitocin. It's what happens to your body when there's too much Pitocin, if that makes sense, that causes that reaction with baby.
And with that being said, like, this is an educational opportunity for the nurses as well. Like,
yes.
If you, like she just said, that 8 to 10 might feel like 8 to 12 to that baby. And so, again, caution how often you're going up on it. No, she might not be contracting now, but in 20 minutes she might, but it's technically time for you to go up on it. Give her some time and kind of watch and see.
I'm going to leave you with a scripture that says you got to watch.
Because you don't want to stress your baby out. So,
also, this is something that put your hands on your patient.
Ooh.
Because, and this is not like I'm not fussing at nurses. This is not that.
You can tell a lot.
But there are often times when it's like, oh, my patient's not contracting. Maybe she is. And you've adjusted your Toco 87 times, because trust me, I've been there, when it's like, well, guys, you haven't seen me in 3 hours because I've been at the bedside trying to find my contraction with the monitor. And they can get frustrating, but their computers, unfortunately, they just don't always work.
Right. I do not.
And if you don't mess around and have an anterior placenta, now you're really struggling. So, sometimes you just gotta put your hand on the patient and feel that uterus, because it's like, I didn't pick up a contraction in the last 5 minutes on the monitor, but I just palpated 3 in the last 5 minutes. So it's like, okay, now we know, and we can tell the doctor, hey, just letting you know, and of course we'll chart this, but you tell the doctor, all they know is
all they see is the strip most of the time.
But when that's another big thing on talking to your providers, and again, making that assessing your patient at all times. And it's like, hey, because the doctor might call and say, why aren't you going up on the pit? She's not contracting. Well, she is. I'm not picking them with the external monitor. I can feel them and they palpate, my own moderate heart, whatever.
Yeah. Good rule of thumb, nurses, educational opportunity. Good rule of thumb for how strong your contractions are by palpation is the face trick. Mm-hmm. So if you touch your nose and feel how your nose feels on the front, that's like a mild contraction. If you touch your chin, that's like a moderate contraction. And then if you touch your forehead, that's what a strong contraction feels like. So just little teaching opportunity. Yeah. And you can teach that to your patients as well. Yeah. They like to know that kind of stuff, like, oh, I'm hurting, but I don't think that they're strong enough, blah, 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 blah. So, yeah.
So, yeah, my girl Pitt, she gets a bad rap, but she does what she needs to do when she's used correctly.
When she's used correctly.
She'll do what you need her to do if you use it right.
Right.
Another way that some providers will induce labor is if you are already dilated. Because we can't do this if your cervix is cleansed. But, okay, it can, but don't do that.
Don't do that. That's not safe.
Yeah. Is that they can break your water. I have seen providers use that as a way of inducing patients, especially if it is not their first baby.
Yeah.
Because it's almost like you break that water, and some patients will even tell you, if you break my water, I'll have a baby.
If you break my water, I go quick.
Yeah. Which, good to know, girl. Let's get you epidural first before we start doing that. And they'll be like, yeah.
And I think more providers are moving towards the Cytotec, the balloon. And as soon as your balloon comes out, as long as your baby is well applied to your cervix, they will break your water before starting PIT. Because I'm sure some research study, and I will find it for you guys, has said that can be more effective by stimulating their own hormones, their own prostaglandins to be released to kick them into labor.
But you know what? I could see that, because when we were just talking about starting Pitocin and not knowing what their body's natural oxytocin is going to do after you break their water, it's kind of like, okay, well, let's see what they do. Let's see what the body can do on its own before, because that way we'll know how much we need to add later down,
which
later
makes
on.
Perfect sense.
Science is really mind blowing, But, and I mean, just to kind of like, we've talked about a lot of things regarding induction, but one of the big things I want to stress is just that everybody's body is different.
Unpredictable. Y'all gonna get enough of me. Oh, real quick before we wrap it all up. Breaking of the water. Let me tell y'all, it is as painful as a cervical exam is. Yeah. People get freaked out. They're like, oh, you're gonna break my water. Is it gonna hurt? Number one, the amniotic sac does not have nerve endings. Yeah. So it's not painful to the baby. They use what's called an amni hook. It looks like a little crochet needle. And I say needle, but if you go look at a crochet needle, not the ones you use for your hair. It's not one. It's not a needle. It's actually very blunt on the end. That is what is used to break the water. And yes, you will continue to leak until you have this baby.
Yeah. Yes. Yeah.
And I will say, breaking of the water, however, like I said, it's as painful as a cervical exam. So if your cervical exam is not that uncomfortable for you, that's what it's going to feel like.
Oh, that's good to know.
Yeah. So Yeah. But I would say breaking of the water like tells us a lot too, like as a provider.
Yeah.
If your fluid is clear, if your fluid is like meconium stained or anything like that, that can be
bloody.
like, or bloody. If your baby is well applied to that cervix and it's essentially creating a stopper and we can't get in, a lot of fluid is not coming out. Or if a lot of times I have checked the cervix, broke water, and like the cervix literally melts in my hand, like as the water keeps coming out.
We should probably get a table.
Yeah. Everybody got gloves on? Okay. Be like, oh, she was 4 and now, wow, okay, she's 8 and 90.
Yeah.
Like,
yeah, it does.
So,
yeah.
But now you can be your...
No. I was just, last little points about how everybody's labor is different. Everybody's induction process is different. Because have I had somebody come in 7 p.m. my shift and at 6:30 something, by the time I got to leave, they had a baby off of one side attack? Sure, I've had it happen. Not often, but I've had it happen. And like
Those
I said,
are like your unicorn people.
I've taken care of her twice.
Oh, hey, so Andrea. She's a special person.
She is. That's my girl. I deliver both her babies. But yeah, there are some people who just come in and that's just how their body reacts to, the medication. There are some people, it takes longer. Doesn't mean you're doing anything wrong. Doesn't mean you shouldn't have come in. Doesn't mean, we're not doing something right. It's truly just trying to find what makes your body work in its optimal place of labor.
Performance.
Yes. And it's just trial of labor. Literally. Trying to figure out,
okay, that didn't work. Let's try this.
Yes, because especially when we're talking about Pitocin, I've been going up on Pitocin, got to 10, it looks good. And it was like, oh, baby, just 12. Then I go up to 12 and the contractions space out even more. And it's like,
I had that to happen.
And it's like, okay, her optimal place is 10. So I go back down to 10 and it's like, voila. And it's like, well, we found our happy place for right now.
Mm-hmm.
So it literally, it's all, and that makes sense because how much is her own body,
making. If her body is making 4 and we only need to add 4 more, that's it.
Exactly. So yes, all labor is different. And again, I don't want you to get discouraged if after 2 doses of side attack, you're still only 2 centimeters.
Or 4.
That's okay.
4 doses is fine. Okay, very quickly, let's also talk about failed inductions.
Mm-hmm.
So essentially you come in for your induction, you and your baby look fine. Your body's like, look, sis, I'm not on board. I'm not ready.
Mm-hmm.
Some places will offer you the opportunity to go home and retry your induction later.
Yes.
I've seen it happen and it works beautifully.
It does.
Like, girl, we'll see you in 48 hours.
I've seen that happen somewhere with twins. Back to that same provider that don't go above 6. Yeah. She came in, had a couple dozen decided that no, it might have been more than that, couple dozen.
Yeah, she was my patient.
Wasn't doing nothing. Nothing.
Not a contraction, not hurting, not
Sent her
nothing.
right on home.
Yeah.
Sent her right on home. Because she looked fine.
Yeah. Her babies look amazing.
Yes. And I think she came back and had like a vaginal.
She did. I went to high school with her.
That's so cool. Yeah. I remember. I definitely, because I think I placed her first dose of side attack like the first time she came in. And
I had her on like day 2.
Yeah. And sent her home. She was fine. Babies were fine. She went home, slept in her own bed, took a couple, took some good showers at home. Yep. That's where I want to be. Ate real food because who want to keep eating hospital food? You don't have to. So yes, it's not always. I think the word failure is what kind of like gets people. Okay, like, I failed, but
no, it's not a failure.
You didn't fail.
We just need to try again.
Yeah, at a different time. That's all. Try different time. But yeah, induction not always a bad thing. Many times it's done just to get you and baby home safely.
Yep. Remember, everything that we do is for your benefit and not your detriment.
Period. With that on a t-shirt. Okay, so yeah, if you guys have any questions, I know I've had some people slide in my DMs about induction, and yeah, I think that might be it. I think we did have this one question slide in our DMs a couple of times. Questions.
We need to talk to Sipo about that. We need like a question segment. Like, I don't know. We'll figure
Isn't
it
there a
out.
song that has the word question?
Asking all them questions. Like,
Okay, please, we're not going to put that.
We will figure it out.
That was funny. I haven't heard that in so long. Like, what, 2010? But we had a couple questions come into our DMs about meconium stained fluid. If you didn't know, so meconium stained fluid is when the baby has a bowel movement in utero. So, many times we don't even know that the baby has done it until the patient's water breaks.
Yep.
And we break, your water gets broken or it breaks on its own, and it might have some discoloration to it. It depends on the consistency and how much poop the baby has done. Sometimes it's very, very thin and it's just watery. It just might be a different color. Sometimes it's kind of thick and gross, and we call that particulate.
It looks
meconium.
like dark green pea soup.
Yeah, looks like your baby, like we took a dirty diaper and was just like, yeah.
And put it in water and spun it around.
Is it disgusting? Sure. But technically, I mean, it's not anything.
It's not anything. So meconium, yes, that is baby's first bowel movement, but the baby is sterile.
Yeah, it hasn't done anything.
It's sterile. It hasn't eaten anything outrageous. It hasn't. So it literally has no smell.
Mm-hmm.
It is very tarry, like sticky.
Mm-hmm.
But yes, it happens. It happened to me.
I would say it happened to.
It is very common.
It's very common. Way more common than people think.
Yes.
Way more common than people think.
It means that NICU will be at your delivery. That's all that means.
It means at one point or another, your baby got the shit scared out of him. Literally. Like, that's kind of what happened. That's all. That's all.
Very, very true.
Nothing, you ain't do nothing bad or anything like that. It was just kind of like, bah! And it just like, oh God, I shit myself. That's literally all that happened. That's it. But thank y'all for tuning in. I hope you learned some things.
Yes.
Definitely slide in our DMs or our comment section. Me and Shay love to get in the comments. Some of you are... I love when y'all get in the comments because I'll be like, ooh, Shay, look at this question.
Yep.
But yes, thank you guys so much for tuning in.
You can follow us on TikTok, Facebook, Instagram, all of our social media,
Twitter,
at The Laborhood Pod.
Yeah. And go listen wherever you get your podcast from. Google, Spotify, Apple. We on YouTube? No? I don't know. Just get in the link tree. And you'll find whatever you need. And that's all we got this week. Bye,
guys.
Bye.